Knock knock. Hi, my name's Jacob. I want to be your nurse today. How are you feeling?
Yeah, I feel a little better than a couple weeks ago, but they just keep poking me and giving me a bunch of shots, and I don't really understand why. I kind of feel like a little pincushion.
Well, that's because you have uncontrolled diabetes, and we're managing it now with insulin.
Diabetes? I'm not even fat.
You don't necessarily need to be fat to be at risk for diabetes. Looking at your charts, there's lots of things that put you in an at risk category for having diabetes, such as hypertension and other things.
Well, I know I'm not in the best health, but I didn't really think that there was too much wrong with me. Would you mind giving me an explanation of my charts?
I thought you'd never ask.
For your medications, you're taking insulin aspart 100 units per milliliter on a sliding scale of 1 to 6 units, 7 units of aspart Novolog in the morning, 20 units of Dedamir, 50 milligrams of losartan, 7 units of aspart, 40 milligrams of pantoprazole, 35 units of Dedamir again in the evening, 8 units of aspart at night, rosustatin 10 milligrams, and uracil diabetic lotion.
For your vitals, you have a blood pressure of 145 over 67 milligrams of mercury. Your glucose is 301. You have 16 respirations per minute. Your O2 is 96%, and you have a pulse of 75. You're also a full code, and you have no known allergies. To give the kids at home a summary of Philip's condition, he's been diagnosed with diabetes for the past 30 years, uncontrolled diabetes, in fact, which led to disease progression causing diffuse upper back dryness, itching, has peripheral lower limb neuropathy, and is non-compliant with insulin regimen. Originally admitted to the hospital with a subdural hematoma after falling off his porch, with possible cause being linked to his Menard's disease and a hypoglycemic event. Manifestations of Philip's disease include advancing stages of mismanagement diabetes, such as neuropathy, integumentary issues, occasional lightheadedness, and presenting polyuria.
Lab values for Philip include an A1C of 8.7, lymphocytes of 12.2%, neutrophils at 73%, a total cholesterol of 240 milligrams per deciliter, HDLs at 30 milligrams, LDLs at 158, VLDLs at 162, sodium at 132, potassium at 4.5, magnesium at 2.1, creatinine at 1.17, an INR of 1.1, platelet count of 133, a hemoglobin of 10, and a hematocrit of 30.5. Patient interventions for Philip include assisting in hourly turning to prevent pressure ulcers from forming, PRN administration of uracil lotion, diet modifications in reducing simple carbohydrates and eliminating refined sugar, and in the instance of a hypoglycemic event, administer D50X IV push over 5 minutes. Patient education for Philip would include the importance of adherence to an insulin regimen. Failure to do so would lead to further eye and kidney injury. We would also educate on proper insulin storage for unopened and open insulin vials. Unopened vials should be refrigerated and kept away from sunlight exposure. Open should be stored at room temperature for 4 weeks, never heated or frozen. Prefilled syringes with 2 types of insulin should be stored needle up for 1 week, and prefilled syringes with 1 type of insulin can be stored needle up for 30 days. Additional information for Philip's disease from the Cleveland Clinic Journal of Medicine include exercise. As for the pancreas, it directly relates to increased beta cell mass, increased insulin production, and decreased glucagon production, as well as increased insulin sensitivity.
Hi, Randy. I'm Mike. I'm going to be your nurse today. How are you feeling? I understand. Let's talk more about COPD, shall we? Randy is a 74-year-old male who has been a smoker for 40 plus years. He has hypertension and high cholesterol. Randy worked construction for the city for his entire life and is now retired. Randy was diagnosed with chronic bronchitis and his father also had COPD. Randy has no known allergies, is on 2 liters of oxygen at home, 15 milligrams of lisinopril, 40 milligrams of metoprolol, 35 milligrams of Lasix, and is on the albuterol inhaler. Randy was admitted to the hospital with shortness of breath, unilateral wheezing, and an irritating cough with dark yellow sputum production. Sputum cultures were taken to rule out possible pneumonia infection. FEV1 spirometry tests show 66% predicted expiratory volume, which indicates gold tooth status, which is moderate. Randy showed slight improvement after bronchodilator treatment. Here's Randy's labs. Some nursing interventions for Randy would be to raise the head of the bed when sleeping to aid with breathing, recommending a low sodium diet to reduce fluid overload, have Randy use the huff coughing method to expel mucus, and administering a nasal cannula when oxygen levels drop. Some patient education for Randy would be to teach the importance of smoking cessation, use pursed lip breathing, resting for 30 minutes before and after eating, refraining from exercise 1 hour before eating, increase protein and caloric consumption, implementing a spacer when taking albuterol, and adhering to his treatment regimen for better outcomes. An article from the National Center for Biotechnology Information claims that over a 4-year period, patients who adhered to their treatment regimens showed improved ABGs such as pH, PaO2, and PaCO2 during COPD exacerbations.